I would like to invite the chairpersons, Dr. Balachandra Ji, who's the Professor of Medicine, Saptagiri Institute of Medical Sciences, and Dr. Indrashish Mukherjee, who's the Research Head, HIMSS, Lucknow. You invite you on stage, doctors.
At the onset, I would like to thank Dr. L. Srinivasamurthy sir to giving me the opportunity to be the chairperson in this prestigious conference. And now I am not taking much time to introduce our next speaker for this session, Dr. N.K. Singh sir. Sir is Chairman RSSDI Jharkhand and ex-governing body member National API, ex-chairman API Jharkhand and CCDSI, edited Millennium Book of Medicine, Associate Editor, Postgraduate Medicine 2021, RSSDI, Case Books Editor-in-Chief, RSSDI, Atlas of Skin and Diabetes, and edited monograph on COVID by ICP API 2023, over 40 national and international publications, Editor-in-Chief, IJCCP, and over to you, sir.
Yeah. Thank you, Chairpersons. Good afternoon. I think this topic, skeletal muscle dysfunction in metabolic disease, Indian perspective. When Dr. Murthy gave it to me, it appeared a difficult task for me to what to talk today. But remember, today we talk about diabetes, we talk about the beta cell, we talk about the kidney, we talk about liver. But I have seen we are hardly talking about the muscles. So let us see what is the role of muscle here. Basically, this is the metabolic engine. And there is some problem. The first point I would like to tell you that the biological paradox of South Asian Indians, there is a metabolic risk and why it is. So we have to first understand what is the unique Indian perspective. Well, you are well aware that around half of Indian adults over 45 had some possible sarcopenia, where there is reduced muscle mass, so your muscle mass is reduced, impaired strength, and crucially decreased metabolic capacity. And then a vicious cycle starts. You have got, by phenotype, a reduced muscle mass, and sarcopenia worsens the glycemic control, so a bidirectional trap is going on. This is a case, I think, from the CME India group, and by Dr. Binay Dandania, our previous speaker. And recently he posted this DEXA. 19 years, age, duration of the diabetes, you see, 1.5 years. You see BMI 23.5, quite good. But you see here the C-peptide is preserved, GAD antibody negative, no DKA. But the problem here is the total body percentage of fat is 42.8. So this case is why important? Because this is the classical thin fat Indian phenotype, normal BMI, but very high body fat. So likely to have higher visceral fat and low muscle mass. So this becomes the severe insulin resistant despite the normal weight. So this point is very, very important. Again, the second case where you also went for the genetic testing, again you see here total body mass fat is 32.7, and this is also a case where there is thin outside. You are thin outside, but fat inside. So thin fat Indian phenotype. So again the mass of the muscle is less, and you become insulin resistance. And then the third problem is the cutoff of the BMI. So if you take the WHO criteria or other criteria, lots of patients you will miss. So normal Indian threshold should be 23, but recently we had at the research retreat, RSSDI research retreat, we had symposium on this, where waist indices like weight and height ratio that outperforms the BMI. So this is not the topic again here, but remember this, if you only go for the BMI metrics, this will mask profoundly the different metabolic realities. What are those? One, we have got a sarcopenic tendency. The thin fat, you can see here, how the global baseline looks like and how the Asian Indian phenotype is there. And then you have the ectopic fat. Increased visceral adiposity occurs despite clinically normal body weight. So this is a very, very important slide where you can see here that the skeletal muscle mass, if you compare with the white people, it is markedly lower in the Indians and South Indians, apart from all the BMI, the ectopic fat, adiponectin, other things. The second problem with us is that we have a daily macronutrient intake which heavily favors refined carbohydrate. Even today we have taken your lunch and you must have taken a high carb diet today also. So this is the problem where you are taking lots of carbs and not the required amount of protein you are taking. So double burden we are facing in India. A predictable outcome of genetics colliding with the environment where we already have an Indian phenotype of low muscle mass and high visceral fat, and then we are taking the dietary imbalance, and that is we are getting the double burden, so this is a problem. And you see here only the 5% macronutrient pivot yields said disproportionate clinical benefits. So you take from that carbohydrate point to here protein, just supplement it. Here Dr. Arvind Gupta is there from the ICMR in DIAB study, sir. So replacing just 5% of carbohydrate intake with protein, this significantly reduces the odds of diabetes, pre-diabetes, and obesity. So how this is going to do? This is due to increasing the muscle mass and satiety and decrease in fat mass. So finally, my first part of talk is that the low muscle mass with high carbohydrate intake triggers a compounding metabolic crisis, and this is the region you can say that we are facing epidemic of diabetes today. Now let us analyze what you are missing today every day. The skeletal muscle deficit here is there. I told you there is a robust metabolic sink for the glucose disposal. And then we have got an inherently lower skeletal muscle mass. So if you take a muscle cross-section, so as you advance your age, muscle mass and repair capacity declines. Even in the women, the postmenopausal decline is happening and declining, and estrogen triggers a sharp drop in muscle force paired with an increase in intra-abdominal visceral fat. And then we have got a tendency to early loss of beta cell function. If you see from the standard decline, so what is happening with the South Asian decline, and again the region could be here, I told you already. So then there imbalance of the hormonal milieu occurs with the depleted side of adiponectin, elevated side of leptin and acestin. And this point is also very important. If suppose you have got enough muscle mass, that does not guarantee you that is a contractile capacity is same. So this functional decline occurs even when the total lower limb muscle mass appears identical to a healthy individuals. So remember, this is very important. The mass is an illusion and quality is the metric. So this point, and then this how this biological causal chains we are missing from the abdominal adiposity, ectopic fat deposition, then we develop the severe insulin resistance and ultimately to metabolic disease. Now let us see what is happening inside your muscle. This is basically the main point of my talk is that muscle is an endocrine organ. And the new paradigm is a metabolically active organ. Muscle is interacting directly with the liver, adipose tissue, pancreas, and the cardiovascular system. And this paradigm we are almost neglecting. So muscle secretes protein called myokines, the chemical messengers that dictate energy metabolism body inside. So if you are not following the regular things like physical activity and sufficient vitamin D, then ultimately there are mechanisms by which a metabolic collapse is going to happen. Because today we are not talking much about the mitochondrial medicine, but diabetes basically is a mitochondrial medicine, where there is healthy process, and then if there is mitochondrial dysfunction, this dysfunction at this primary site directly causes insulin resistance, a condition that is you aggravate by the high fat, high sugar diet. So remember, and then there is insulin resistance loops occurs with this sarcopenia and less of muscle mass, where you get more and more and more muscle loss, and impaired glucose uptake triggers insulin resistance. So this is happening. And then this myokine factory, by your deeds, without your diet, your inactivity, you are just going to defunct your myokine factory inside your muscle. So this is very important that lots of pathway, I'm not going to discuss that IL-6 pathway or adenosine pathway, how they are doing, but more muscle mass if you have, higher secretion of several myokines, that will regulate glucose and lipids, remember. And so then the third part is intramuscular fat is very, very dangerous. So there is fat inside the muscle, you see here. So the spark is there, then the fire is there. That triggers secretion of pro-inflammatory cytokines, like TNF-alpha or IL-6, leptin resistance, and then ultimately the fallout occurs with these all elevated markers, and you develop systemic insulin resistance and de novo fat synthesis in the liver. And then also vitamin D role is very, very important here. This is a nuclear vitamin D receptor is native to human skeletal muscle. So low levels are directly related to sarcopenia independent of metabolic syndrome. So remember, this deficiency is very, very, you have to take care. And then ultimately with anabolic resistance of the physical inactivity, muscle disuse, you are not using your muscles every day, decreased energy consumption, you are taking more and more carbs and other things, then you are depositing fat inside your muscle, systemic inflammation is occurring, and then no weight change is required, you get a liver fat like this here. So this then you occurs, this muscle is so key factor, so important that it is the, I think in the, should be center of this metabolic syndrome. The third, so there is a paradigm shift is occurring. A microvascular dysfunction is an early driver of insulin resistance. And current data favors that microvascular dysfunction and hyperglycemia gives you a bidirectional relationship. So this is very important again. So this part of my talk says you that a skeletal muscle is the body's largest endocrine organ, and its deterioration is a primary driver of the systemic insulin resistance, chronic inflammation, and organ disease. Now, how to catch it early? This is very, very important. This was a theoretical part. This is happening. But now we are going to discuss how we are going to catch it early in your clinic. The patient presents with comorbidity, coming with your diabetes. But I don't think in our clinics we are going for just looking, we are not looking for the sarcopenia screening at all. So if you are going to check it early, so what is, I think very simple things you need require. This is a machine where you can get the low muscle strength, you can get definition. First you know about the definition, I will tell you other things. Based on the expert panel for the Indian population, that if in that machine, the male threshold is less than 27 and female is less than 18. And the first you have identified risk patient, you can have an initial screen with the SARC-F questionnaire, you are well aware about that. And mandatory screening checklist should be all patients with the chronic comorbidities, all individuals more than 60, patients with prolonged immobility, and patients exhibiting malnutrition or normal weight obesity. So how you are going to do that? This is the easy to do in clinics. You just ask about a strength, assistance in walking, rise from chair, climb stairs, fall, and you will get this scoring reachable level. But about this hand grip dynamometer, not a big machine. You have got it. You got in my clinic also. So very simple machine. Muscle strength you can get, then you muscle function for 5-chair stand test. Then you can have your calf circumference tested also. And if you have got, then DEXA is the gold standard, you know. Or this imaging alternative we are not doing, ultrasound of the rectus femoris, so I not get. And then ultimately, I think most of the clinics today, they have got a BCA machine. I think lots of companies have distributed it. So you can have a bi-electrical impedance analysis, and this is considered as a poor man's DEXA. Dr. Gupta, you are doing routinely, I think. So this is a very also, so if you don't have DEXA, you can go for that, this by this machine. And then our Indian diagnostic cutoff is for males, the grip strength, calf circumference is 34, less than you see here. For females it's different, gait speed and 5-chair stand test, a stand test. So ultimately this tool is important, the role of AI is there. but I will skip it. So I think you just identify, assess the muscle strength, assess the muscle mass by the BIA or if you have got the DEXA, and then evaluate the physical function. And then you can have early you can catch up the sarcopenic patients. And then you can go for the interventions. So I think this summarizes everything I told you, how to find the cases, assess, confirm. We have lots of means. I have not told you many big things. I have told you simple things by which you can diagnose such cases. And this is if you can do nothing, this is a UB Wakka, finger ring test. Although just I got only one paper, just see here, and by that also you have some idea about this, your sarcopenic patients. Now the last part, I have got 5 minutes, how you are going to regenerate your muscles. Now you have got the pathophysiology known, you have got the big problem with the muscles, you have known about that muscle is an endocrine organ, is the center part of your diabetes or metabolic diseases. How you are going to regenerate your muscles? The 4 pillars of muscle regeneration should be remembered. Tissue repair is highly energy demanding. So that requires 4 distinct metabolic pathways. One is the glucose metabolism, you have to understand. The second is the fatty acid oxidation. Third is the amino acid. And then how you are going to do good for your mitochondria. Number 1 is, remember, Dr. Sanjay will be talking about physical exercise. So number 1 pillar of regenerating your muscle is nothing but targeted physical training. That is very important. You go for the resistance training, aerobic training, or balance training. So this is important. And remember, this training is non-negotiable medical therapy. Nothing matches like that. Protocols are lots of there, but just one thing is very important. We are telling our patient, go for running, go for walking, but how many times you are telling your patient to do the resistance exercise? This is so important today. And the third pillar is the MNT, that is the macronutrients, micronutrients, and some specialized nutrients coming up. I am not going to detail, this is not my topic, but anyway, the feeding the muscle is very important by protein, vitamin D. Now lots of people are also using creatinine. At least those who are going to gym. They start with the 20 gram per day, then 3 to 5 gram per day increases. And that also, we have got some evidence that increases lean mass and the physical performance. Then the omega-3 fatty, and recently, the role of magnesium is also coming up to take at least 300 milligram per day for men and 270 milligram per day. So, but if you go for so many drugs are in the pipeline or in the market, but reality is whether you talk about a testosterone or a DHEA, insulin-like growth factor, lots of things are there, but no drug translated into clinically relevant improvement on physical performance. Remember, you are all also heard about this spermidine and sarcopenia. Lots of pharma companies are selling it, but I have to tell you that this is not a proven one. This is not an evidence-based management at present. But creatinine is a metabolic powerhouse for muscle recovery. We have got evidence. So this is just like saying that I have just ordered a chicken and an egg online. I wonder what will come first. And then there we have got drugs like metformin, GLP-1RA, or SGLT2 inhibitors. The metabolic drugs give you direct microvascular benefits. Now look this. World leader holder in both the 5,000 meter and 10,000 meter from 2004 to until 2020, he won the gold medal in the both. So does he look sarcopenic? Think yourself. So my concluding points are that the master clinical algorithm is nothing home to screen, how to assess, then what to do, and how to monitor. The swift diagnosis is very, very important. So this is the skeletal muscle dysfunction is a central driver of insulin resistance and cardiometabolic risk. In India, we have got a thin fat Indian phenotype. We have got a low muscle mass, poor muscle quality, and postprandial glucose disposal is muscle dependent. Hence, muscle health is critical in diabetes prevention and control. And high burden of physical inactivity, protein deficient diets, and vitamin D deficiency is happening in India. So you can deal it with so many things I told you, the resistant and adequate protein, early identification, Even the emerging therapy required muscle preserving strategy, because if you are starting the GLP-1 RA, you know there is some problem with the muscles. So you have to do also resistance exercise again. For the worsening sarcopenia, very important point. This is my last slide, was very important slide. If you just bring back the traditional Indian physical activities, see here, embrace the nature, and just bring back the traditional Indian food, lots of problems, all the problems I told, that will you will have go to the end. Thank you very much. Thank you.
Thank you. It was really wonderful, because most of the times diabetes, people do not talk about skeletal muscle.
Yes, sir.
And when we do see, probably we think that...
Sir, that's why, sir, Dr. Murthy has some vision for that.
Yeah.
He kept this talk.
Yeah. So, any questions? One question can be...
Sir, Dr. Gupta, if you are doing lots of BCA in your clinic, I have seen. So what is your experience with that machine? Whether we should go for DEXA or...
No, first important thing is that you have wonderfully presented regarding the insight about the misconception about the BMI. It's a BMI is not the only thing, it is the actually skeletal muscle, fat mass, and not only the visceral fat and the subcutaneous fat, it is the ectopic fat, which is the most atherogenic fat in our body. So you have pointed out absolutely perfect. Another point, we are also doing the Pan-India project. Still pilot project is going on in our hospital in Jaipur, and where we are doing the comparison of Indian phenotype, especially the DEXA, as well as in-body analysis by the BIA, bioimpedance.
So that is my question.
Yes.
What is your experience till now?
So experience is that, first of all, we are all protein deficient. We have recently published in Nature Medicine, ICMR in diabetes study, almost all India, whether the east, west, north, or other areas, all are having the protein deficiency. So that is the first and foremost thing. Another thing is we usually found the sarcopenia even in around 40 to 50 year old
younger
people.
generation, yeah.
Because of the severe protein deficiency, they are not having resistant exercise.
Yeah.
So they are doing, some people are doing the walking and everything, but resistant exercise is very, very important. So two things, protein and the diet and the resistant exercise from our own experience till date, but the data will tell later
Okay,
on.
thank you.
Thanks. Thank you, sir.
Thank you.
So almost just, there is time for a question. Is there time for a question, sir? Yes.
Okay.
Yeah, it's almost since 15, 20 years, not necessarily doctors, but there's so many people who are promoting nutrition, like in the various trade names. Even they are using some of the scanning machines, and they're also interpreting like the same things what we said, your muscle is less, your fat is more. How authentic, and first of all, it is not very, it is not as popular scanning the muscles and all that. What is the instrument that we use, and is it what we see in front of every park using, is it authentic?
Yeah, sir. I told you that the DEXA is not possible for me also in my clinic to do. It is a costly test. I have got the BCA machine, but also that I am not doing free. So it costs also 1,000 rupees. So basically the hand grip, that dynamometer, that is very cheap. Very 500 or I think around cost only. And that gives you a good idea, and you can have some calf measurements. So these few things you can do. And by that you can have some idea about that SARC questionnaire, that is a not big one, that is you can do free online. So that things you can do in your clinic.
Thank you, sir.
Thank you so much, chairpersons and speaker. Would request you to kindly move to the selfie area.